A 14-year-old male presents with deep, aching arm pain and a mild fever. I'm showing you the radiograph of the humerus. Describe the findings.
Okay, I see it. The humerus radiograph demonstrates a relatively well-defined osteolytic bone lesion centered within the midshaft diaphysis. The lesion exhibits a narrow zone of transition and is associated with endosteal scalloping. There is also a smooth lamellated periosteal reaction surrounding the shaft, without evidence of a cortical breakthrough or a distinct soft tissue mass. These non-aggressive findings of a solitary lytic diaphyseal lesion in a child are highly suggestive of an eosinophilic granuloma or subacute osteomyelitis.
What is the differential diagnosis for a solitary lytic bone lesion in a child? And how can we differentiate eosinophilic granuloma from infection?
The differential diagnosis includes eosinophilic granuloma, acute or subacute osteomyelitis, fibrous dysplasia, leukemia, and lymphoma. Differentiating eosinophilic granuloma from osteomyelitis can be challenging because both present with local bone pain, low-grade fever, leukocytosis, and elevated inflammatory markers. Radiographically, osteomyelitis may show a sequestrum, involucrum, or a cloaca, while an eosinophilic granuloma classically presents with lamellated periosteal reaction and progressive scalloping. In the skull, eosinophilic granuloma shows punched-out lucencies with a beveled edge or double contour due to unequal destruction of the inner and outer tables, which is not seen in infection.
Explain the pathology of Langerhans cell histiocytosis and typical locations for skeletal involvement.
Langerhans cell histiocytosis is a spectrum of disorders characterized by the clonal proliferation of pathologic histiocytes that express CD1A, Langerhans, and S100 proteins. Eosinophilic granuloma is the localized skeletal subtype, which accounts for the majority of cases and is most commonly seen in patients aged 5 to 30 years. It has a strong predilection for flat bones, with over half occurring in the skull, pelvis, mandible, and ribs. In long bones, it typically involves the diaphysis, and the growth plate serves as a strong barrier, preventing extension into the epiphysis.
What is the prognosis and typical clinical course for skeletal eosinophilic granuloma?
In that case, skeletal eosinophilic granuloma has an excellent prognosis, with many lesions undergoing spontaneous resolution and osseous remodeling within 6 to 18 months. Because of this self-limiting course, management is often conservative. When intervention is required, curettage with or without bone grafting, steroid injection, or low-dose radiation can be performed. Patients must be monitored to ensure the lesion is not part of a systemic, multi-organ Langerhans cell histiocytosis presentation, which would carry a more guarded prognosis.
How would you manage this patient as a radiologist?
Well, as a radiologist, I would recommend comparing these radiographs with prior arm films to evaluate for changes in the periosteal reaction. I would strongly recommend an MRI of the humerus to evaluate the extent of marrow edema, confirm cortical integrity, and rule out any associated soft tissue mass. I would suggest a low-dose skeletal survey or a skull radiograph to check for asymptomatic lesions elsewhere in the skeleton, which would confirm a multifocal presentation. Finally, I would document the findings, recommend correlation with laboratory inflammatory markers, and refer the patient to pediatric orthopedics for a biopsy, which is necessary to confirm the diagnosis and rule out malignancy.